Dr. Thomas Weiser. Captain Weiser is the medical epidemiologist for the Portland Area Indian Health Service, assigned to the Northwest Portland Area Indian Health Board and Northwest Tribal Epidemiology Center. He has been with the Public Health Service since 1998, initially serving as an IHS medical officer in White River, Arizona from 1998 until 2005. He completed the CDC Epidemic Intelligence Service from 2005 to 2007, and in 2007, he began his current position. In addition to supporting general public health and epidemiologic research at the Northwest Tribal Epidemiology Center, Dr. Weiser is also the co-chair of the Portland Area IHS Institutional Review Board. Nationally, Dr. Weiser serves on the IHS Heroin, Opioids, and Pain Efforts Committee as the chair of the Metrics Subcommittee. Since 2018, he has served as the IHS ex officio representative to the CDC Advisory Committee on Immunization Practices. Dr. Weiser, thank you for being willing to share your knowledge with us today, and please take it from here.
Hi, good morning, everyone. It's a pleasure to be with you. And I hope that you'll find that this information is helpful as you're either thinking about getting vaccinated for those who haven't been vaccinated yet, or in your discussions with patients and coworkers and others that you might have. So whether you're a doctor or a nurse, a medical assistant, or a member of the check-in staff or facilities management, you all serve in the healthcare setting, and therefore you're first in line for the COVID-19 vaccine. So today we're going to cover what we know about the vaccines and try to arm you with the information that you need to make a good decision about getting one. We'll go to the next slide, please. So this graph here shows you that as of March 6, there were over 116 million cases worldwide with over 2.5 million deaths. And in the US, we've had over 28 million cases and more than 500,000 deaths. And that's about 1/5 of the total world number of deaths. And the graph shows the epi curve of COVID-19 in the US. So these are the daily cases. And then the red line running along the top is the 7-day moving average. The concern here is that when you look at the cases and the red line, it seems to have leveled off over really the past 3 weeks instead of continuing its downward trend. And this is quite concerning. Next slide. So this table shows you the data for the 3 states in the Bemidji area. And you can see that Michigan has the highest number of cases with 570,101. But that Wisconsin has the highest number of cases per 100,000 population, 9,747 per 100,000. Michigan also has the highest number of deaths and the highest number of deaths per 100,000 population. Next slide. So when COVID first began, many of us heard people comparing it to the flu and thinking that, well, isn't it just like the flu? But the reality is that it's much more serious than the flu. Next slide. So this graph comes from the CDC COVID view, and it shows time in weeks on the x-axis. And on the left vertical axis, it's the percent of all deaths due to pneumonia, influenza, and COVID-19. And this is tracked by the red line that you see going across the graph. On the right vertical axis is the total number of deaths that are coded as influenza. And these show up as the little gold areas in the bottom, or as COVID-19, which shows up as the blue area on the right. So if you focus on that x-axis, you see the seasonal distribution of influenza deaths, those gold little epi curves. And the highest was in 2017 and 2018 season. In fact, that year was the worst flu season since the 2009 H1N1 epidemic. So now compare that with that W-shaped blue portion on the right side of the graph that reflects a much larger number of deaths overall and weekly from COVID-19. And again, the red line that tracks all this, showing the percent of all deaths due to pneumonia, influenza, or COVID-19 is also much higher during the pandemic period than in any flu season, even the 2017-18 flu season. Next slide, please. When we think about the total number of cases of flu during a bad flu season and in COVID-19, we see that COVID-19 has had about 60% of the total number of cases, as in that very bad flu season. Next slide. But COVID-19 has 30 times the number of deaths, making COVID-19 much more deadly than flu. Next slide. The impact of COVID on people of color has been much greater than for whites. American Indian Alaska Natives, outlined in the red box, have experienced twice as many cases per 100,000 population, almost 4 times the number of hospitalizations per 100,000 population, and 2.4 times the number of deaths per 100,000 population compared to white non-Hispanics. Next slide, please. So why is all this so important? First of all, COVID-19 infection is a serious condition that is responsible for an enormous burden to our healthcare system, both in terms of ER visits and hospitalizations, and has caused significant mortality in the US and globally. Secondly, compared to the worst recent influenza season, the number of deaths from COVID is over 30 times higher, making COVID-19 much more deadly than influenza. And third, American Indian and Alaska Native persons have the highest infection, hospitalization, and mortality rates for COVID-19 compared to any other race or ethnicity. Next slide. So now that we've established that COVID-19 is a serious illness that is disproportionately impacts the American Indian and Alaska Native population, let's take a moment to review what we know about COVID-19. We know that the infection with SARS-CoV-2, which is the virus that causes COVID-19, can result in a range of illnesses, from mild symptoms to severe illness and death. About 30% of persons infected with SARS-CoV-2 do not have any symptoms at all. We can't really predict how severe any person's illness might be, but we have learned a lot this year, and we know that certain factors may increase your risk. Some people are more likely than others to become severely ill when infected, such as older adults or people with certain medical conditions like diabetes, obesity, cancer, or heart disease. Next slide. We've also learned about actions that we can all take to help prevent COVID-19. Wear a mask that covers your nose and mouth. If you can, wear 2 masks or even use the knotted method that CDC has rolled out recently. Avoid close contact with others as much as possible. Avoid touching your face, your eyes, nose, and mouth with unwashed hands. Clean frequently touched surfaces regularly. Wash your hands with soap and water for at least 20 seconds. And use an alcohol-based hand sanitizer with at least 60% alcohol if soap and water are not readily available. So these are all tools in our toolbox. And the more tools we use to prevent the spread of the virus that causes COVID-19, the safer we'll all be. Next slide, please. So now we're adding more tools to our toolbox, namely COVID-19 vaccines. Multiple COVID-19 vaccines are in various phases of development in the United States and worldwide. The federal government is funding and coordinating the development of multiple vaccine candidates, and 3 of these have already been authorized for use, and more are in phase 3 trials at this time. You can see the phases which are standard to all vaccine clinical trials on this slide. The most promising treatments are moved into clinical trials. And as new treatments move through a series of steps called phases. More information is gained about the treatment, its risks, and how effective it is. Phase 1 involves 20 to 100 healthy volunteers. Researchers try to answer questions like, is this vaccine safe? Are there any serious side effects? How does the vaccine dose relate to any side effects? And is the vaccine causing an actual immune response? In phase 2, we're involving now several hundred volunteers. And researchers here try to answer questions like, what are the most common short-term side effects? What's the body's immune response? And are there any signs that the vaccine is actually protective? The third phase involves 1,000 or more volunteers. Researchers here try to answer questions like, how do disease rates compare between people who get the vaccine and those who do not? And how well can the vaccine protect people from disease? So it's important to note that safety data on these vaccines are collected in all 3 phases of the clinical trials. The fourth phase happens after the vaccine is authorized or approved. And in phase 4, researchers continue to collect data on the vaccine's long-term benefits and side effects. Next slide, please. As of today, 3 vaccines have received emergency use authorizations from the FDA. There are 2 mRNA vaccines, one produced by Pfizer-BioNTech and the other produced by Moderna. The manufacturers reported that phase 3 trial results demonstrated that both vaccines were approximately 95% effective at preventing COVID-19 disease. Both vaccines are administered with a 2-dose schedule separated by a few weeks. And on Friday, February 26th, the FDA authorized the Janssen adenovirus vector vaccine, which is a single-dose vaccine that was shown to be 66.3% effective in preventing symptomatic laboratory-confirmed COVID-19 at 14 days or greater after vaccination, and 65.5% at 28 days after vaccination among all participants in the study. Vaccine efficacy was higher in the US arm of the study at 74.4%. And none of the vaccine recipients were hospitalized or died related to COVID-19 infection, compared to 16 hospitalizations and 7 deaths in the placebo group. In the United States, these vaccines were authorized using FDA's Emergency Use Authorization, or EUA. And EUA is a process that helps facilitate the availability and use of medicines and vaccines during public health emergencies such as the COVID-19 pandemic. The known and potential benefits of a COVID-19 vaccine must outweigh the known potential risks of the vaccine for use in order to receive an EUA. I want to emphasize that COVID-19 vaccines are being held to the same safety standards as all vaccines. Next slide, please. Many people want more information about the vaccine trials that led to the release of the COVID-19 vaccines that are available now. As of December 21st, 2020, more than 45,000 volunteers were enrolled in phase 3 of the Pfizer-BioNTech COVID-19 vaccine trial. More than 43,000 have received both doses of vaccine. The vaccine trials are being conducted at approximately 150 sites domestically and internationally. In 39 US states are represented in the study. Among US participants, 13% identified as Hispanic, 10% as African American, 6% as Asian, and 1% as Native American. 45% were aged 56 to 85. For the Moderna vaccine, as of October 22nd, more than 30,000 volunteers were enrolled in phase 3 of the Moderna COVID-19 vaccine trial. And more than 25,000 volunteers have received both doses of the vaccine. The vaccine trials are being conducted at approximately 100 sites across the US. And among participants, 20% identified as Hispanic, 10% as African American or Black, 4% as Asian, and 3% as all other non-whites. 64% of participants were aged 45 to 65 and older. Next slide, please. Finally, for the Janssen vaccine, or Johnson & Johnson, as of February 4th, 2021, based on data submitted to the FDA, more than 43,000 volunteers were enrolled in phase 3 of the Janssen vaccine trial. The vaccine trials are being conducted in 8 countries, including the United States, and on 3 continents. Among participants, 45% as Hispanic, 19% identified as African American, 3% as Asian, and 10% as American Indian or Alaska Native. However, the vast majority of those who were Native were from outside the US. 34% of participants were aged 60 and older. So as you can see, all 3 vaccines were tested in diverse adult populations, including minorities and older adults. Data from the clinical trials show that all 3 vaccines are safe and effective at preventing COVID-19. Next slide. When vaccines were first released, there was a limited supply, and certain groups were recommended to get a COVID-19 vaccine first. As part of the healthcare system, you are on the front lines of this pandemic and are at high risk of exposure. You can also potentially transmit the virus that causes COVID-19 to populations that are themselves at higher risk for severe COVID-19 infection. This includes older adults and those with certain medical conditions. As part of the healthcare system, many healthcare personnel have received their COVID-19 vaccine. Some healthcare personnel have chosen to wait or may be unsure. We recognize that these healthcare personnel might have a lot of questions, and we hope that this presentation can help answer them. Next slide, please. So let's talk a little bit more about the first vaccines that became available, the messenger RNA or mRNA vaccines. mRNA vaccines are a new technology that teaches our cells how to make a harmless piece of what is called the spike protein. One advantage of mRNA vaccines is that they are not made from the live virus that causes COVID-19. Therefore, there's no chance of getting the disease from the vaccine. Another big advantage is that they are developed in the laboratory using readily made materials, unlike traditional vaccines, which are grown in cells or eggs, which allows them to be manufactured much faster. It's important to note, however, that the mRNA does not enter into the cell's nucleus, so it does not affect or interact or alter our DNA in any way. There is a common myth about mRNA vaccines, but mRNA vaccines in COVID-19 do not interact with DNA. And while there are no currently licensed vaccines using this mRNA technology, the technology has been studied for decades in vaccine trials for influenza, Zika, rabies, and cytomegalovirus, and also in certain cancer treatments. Next slide, please. This is a diagram from one of the publications about the Pfizer vaccine, and it shows how the mRNA vaccines work. The lipid nanoparticle is basically a small sphere made up of fat molecules. And the mRNA message is inside the lipid nanoparticle. And once it gets into the cell, the message is retrieved and translated to form the same spike protein found on the surface of SARS-CoV-2. After the protein piece is made, the cell breaks down the nanoparticle and the mRNA and gets rid of them. Next, the cell displays the protein piece on its surface. And our immune system recognizes that that protein doesn't belong there and begins to build an immune response and make antibodies, which are what protect us from getting infected if the real SARS-CoV-2 virus enters our bodies. Next slide, please. So what do we know about how these mRNA COVID-19 vaccines are administered? We know that 2 shots are needed to provide the best protection against COVID-19 for both of the mRNA vaccines. The first shot primes the immune system, helping it recognize the virus, and the second shot strengthens the immune response. As we mentioned previously, for the 2 vaccines currently authorized, Pfizer-BioNTech vaccine requires 2 shots 21 days apart, and the Moderna vaccine requires 2 shots 28 days apart. Both doses of the series should be completed with the same product. mRNA vaccines are expected to produce symptoms after vaccination, and especially after the second dose. Side effects may include fever, headache, and muscle aches. These are similar to side effects you might experience after any other adult vaccine, such as the flu vaccine or the shingles vaccine. Side effects are an indication of a good immune response, so while they may be unpleasant, it means the vaccine is doing its job. The side effects are generally short-lived, and you should feel better within a day or 2. Next slide, please. At least 8 weeks of safety data were gathered in the clinical trials, and it's unusual for side effects to appear more than 8 weeks after vaccination with any vaccine. The clinical trials did not reveal any significant safety concerns. However, a small number of severe allergic reactions have been reported during the initial rollout of the vaccines more broadly. If you get a COVID-19 vaccine, you'll be asked to stay for a period of time afterwards to monitor for any signs of a potential allergic reaction. If you've had no history of allergic reactions to vaccination, you'll be asked to stay for 15 minutes. And if you've ever had an allergic reaction to vaccination, you'll be asked to stay for 30 minutes for observation by a healthcare provider. If you think you might be having a severe allergic reaction after you've left the vaccination site, you're urged to seek immediate medical care by calling 911. And more information about this can be found on the CDC's website. Next slide. So this diagram goes over how the Janssen adenovirus vector vaccine works. In this vaccine, the COVID-19 spike protein mRNA has been spliced into an adenovirus. This is shown by that dark blue shape in the figure in the left-hand corner. And that's capable of entering human cells, but it can't replicate, it can't reproduce or make new copies of itself. Once inside the cell, which is that turquoise sphere in the figure, The mRNA is used to create the spike protein, similar to the way the mRNA vaccines are produced the spike protein. And then this spike protein will be expressed on the cell surface. The immune cells, primarily in the nearby lymph nodes, will recognize this and produce antibodies and also stimulate cytotoxic T cells, producing both humoral and cellular immunity. Next slide. For the Janssen vaccine, only one shot is needed to provide protection against COVID-19. And the most common side effects include muscle aches, fatigue, and headache. Side effects generally last only a day or two, similar to that for the other mRNA vaccines. Next slide. Again, I want to emphasize that although the vaccine timeline was fast-tracked for emergency use authorization because of the pandemic, the COVID-19 vaccines are being held to the same safety standards as other routine vaccines. Several expert and independent groups are evaluating the safety of vaccines being given to people in the United States. Before any vaccines receive authorization or approval, FDA carefully reviews all the safety data from clinical trials. And the Advisory Committee on Immunization Practices, or ACIP, which is an independent body of experts, reviews all the safety data before recommending their use. FDA and ACIP have qualified scientific and clinical experts with minimal conflicts of interest reviewing all of the data. After any vaccines are authorized and in use, both FDA and CDC continue to monitor the safety of vaccines. Existing systems have methods that can rapidly detect possible vaccine safety problems. These systems are being scaled up for COVID-19 vaccine introduction to fully meet the needs of the nation. Additional systems and data sources are also being developed to further enhance safety monitoring capabilities. Next slide. IHS has 3 systems in place for monitoring vaccine safety. The Vaccine Adverse Event Reporting System, or VAERS, is a passive surveillance system that is co-managed by CDC and the FDA. Patients and providers can voluntarily report any concerns they think might be related to a vaccine into VAERS. A new feature added to VAERS reporting forms this year is box 26 for indicating if the vaccine was given by IHS or a tribal facility. This will indicate reports that will be shared with IHS for further analysis and tracking. iStar is used to collect employee-related injuries or illness for IHS. Adverse reactions after employee vaccination should be documented in both VAERS and iStar. It's also used to collect any administration errors that might occur. And finally, the National Pharmacy and Therapeutics Committee Vaccine Sentinel Survey is conducted every 2 weeks across 58 participating IHS and tribal sites to collect information about adverse events from COVID vaccines occurring in those sites. Next slide. Monitoring vaccine safety is a regular ongoing part of vaccine development. And another system for monitoring vaccine safety is vSafe, an active surveillance system that uses text messaging to initiate web-based survey monitoring. Both VAERS and vSafe are required to monitor safety effects by race and ethnicity. Next slide. So what are the benefits of getting a COVID-19 vaccine? COVID-19 vaccination will help keep you from getting COVID-19 by creating an immune response in your body against the virus without your having to experience the illness. Based on data from clinical trials, getting a COVID-19 vaccine can greatly reduce your risk of getting seriously ill, even if you do get COVID-19. Getting vaccinated may also help protect people around you, your family, your coworkers, and patients, particularly people at increased risk for becoming severely ill from COVID-19. Next slide. COVID-19 vaccination will also be a safer way to help build protection. Getting the virus that causes COVID-19 may offer some natural protection or immunity, but experts don't know how long this protection lasts, and the risk of severe illness and death from COVID-19 far outweighs any benefits of natural immunity. COVID-19 vaccination will help protect you by creating an antibody response. Next slide. COVID-19 vaccination is an important tool to help stop the pandemic. But again, it's just one tool in the toolbox. While COVID-19 vaccines are highly effective, additional preventive tools will remain important to limit the spread of COVID-19. The combination of getting vaccinated and following CDC's recommendations to protect yourself from others will offer the best protection for COVID-19. Even after you get vaccinated, healthcare personnel will still need to cover their nose and mouth with a mask, avoid close contact, maintain social distancing, clean and disinfect frequently touched surfaces, wash their hands. It will take time to vaccinate all Americans. While the vaccines are being delivered, it's important that everyone continue to take all steps to prevent the spread of COVID-19. Next slide, please. As COVID-19 vaccine becomes more widely available, you may hear more information and misinformation from your friends, family, social media, and peers. Accurate information is key, so we want to review some key facts. COVID-19 vaccines will not give you COVID-19. As we've mentioned before, none of the COVID-19 vaccines currently in use or under development in the United States uses a live virus that causes COVID-19. People can experience side effects such as fever after receiving the vaccine, especially after the second dose of mRNA vaccines. These side effects are normal and are signs that the body is building immunity. It is also important to note that it typically takes a few weeks for the body to build immunity after vaccination. That means it's possible a person could be infected with the virus that causes COVID-19 just before or just after vaccination and get sick, because the vaccine has not had enough time to provide protection. And I think we're one slide ahead. If you can go back one. There we go. Another fact, COVID-19 vaccines will not cause you to test positive on COVID-19 viral tests, such as nucleic acid amplification tests or antigen tests. Vaccines currently authorized or in clinical trials in the United States won't cause you to test positive on viral tests, which are used to see if you have a current infection. If your body develops an immune response, which is the goal of vaccination, there is a possibility that you may test positive on some antibody tests. Antibody tests indicate that you may have some level of protection against the virus, either from previous infection or from vaccination, depending on the test. Next slide, please. Due to the severe health risks associated with COVID-19 and the fact that reinfection with COVID-19 is possible, vaccines should be offered to you regardless of whether you already had COVID-19 infection. At this time, experts do not know how long someone is protected from getting sick after recovering from COVID-19. The immunity someone gains from having an infection called natural immunity varies from person to person. And current evidence suggests that natural immunity may not last very long. And we won't know how long immunity produced by vaccination lasts until we have more data. Next slide. So I just added this slide. It's breaking news from this week. CDC released guidance on Monday, March 8th. It applies to those who have been fully vaccinated, but does not change the precautions that healthcare personnel need to follow in healthcare settings. This guidance will be important for strengthening individual reasons for getting vaccinated. What's changed is that now, for those who have been fully vaccinated, you can gather indoors with other fully vaccinated people without wearing a mask. And I want to stress too, this is in small numbers. This isn't large gatherings. You can gather indoors with unvaccinated people from one other household without masks, unless any of those people or anyone they live with has increased risk for severe illness from COVID-19. And if you've been around someone who has COVID-19 and you are fully vaccinated, you do not need to quarantine or get tested unless you have symptoms. Exceptions include those who live in group settings, like in a correctional or detention facility or a group home, and have been exposed to someone with COVID-19. In that case, quarantine and testing are still recommended, even if the person doesn't have symptoms. Next slide. COVID-19 vaccination can protect you from serious illness and potentially reduce the risk to your family, your friends, coworkers, patients, and your community. Choosing to get vaccinated when it's available to you is an important way to stay safe. Participation in vSafe and helping CDC monitor for any health effects after vaccination is also really helpful. Share your experience with your coworkers, friends, and family, and visibly show that you received a vaccine, such as by wearing a sticker or button. You have a role in increasing confidence in COVID-19 vaccination, and sharing your experience may help influence those you care about. But just be careful. For privacy purposes, please do not show your vaccination card on social media, as it might contain some of your personal identifying information that you don't want to share on social media. Next slide. So these next few slides, I'm going to just talk about how to address vaccine hesitancy when you're talking with patients. And you can also use these tips when talking with family members or coworkers as well. I understand that next week you'll be having another presentation that goes into more depth about vaccine hesitancy. So hopefully this will just prime the pump for you. Next slide. So what is vaccine hesitancy? The term vaccine hesitancy has been defined by the WHO SAGE working group and refers to a delay in acceptance or refusal of vaccination despite the availability of vaccination services. It's an important issue with regard to increasing and maintaining coverage for routine pediatric, adolescent, and adult immunizations. And it also has a role when discussing COVID-19 vaccinations. Vaccine hesitancy is complex and context specific. It varies across time, place, and vaccines. And it's influenced by factors such as complacency, convenience, and confidence. Next slide. This figure demonstrates the vaccine acceptance or hesitance continuum as a pyramid. The labels describe both the views and the behavior. And the middle row is described as hesitant. This is the population which we need to focus our efforts. In this group, people are not adamantly opposed to vaccination. That's just the tip of the pyramid. But they have a lot of concerns. Our ability to answer their questions and provide reliable assurance is critical to moving those who are hesitant into the larger pool of those who accept vaccines. Next slide. So why should we be concerned about vaccine hesitancy? Vaccine hesitancy is a looming threat to successfully vaccinating against COVID-19. We are still in a time of limited supplies in which most jurisdictions are strictly prioritizing who can be vaccinated, but the supply is expected to expand significantly in the coming months. In economics, supply and demand usually go in opposite directions. During the time of low supply, the number of people who want a vaccine but cannot obtain one is high, and that increases demand. Once supplies increase, demand typically declines. Multiple factors influence our demand for vaccination, such as the disease context, community factors, and vaccine-specific issues. For COVID-19, it's well established scientifically that the disease can be serious, with more than 500,000 deaths since the beginning of the outbreak. And as we said at the beginning, the number of deaths from COVID is more than 30 times the number of deaths experienced during the most severe recent flu season. However, the risk of serious illness and death is greater among those who are older or have underlying medical conditions, and up to 30% of individuals do not experience symptoms at all. We know from 2 surveys, including large numbers of American Indians, Alaska Natives, populations, that many respondents do not feel their risk of experiencing severe disease is enough to warrant getting vaccinated. These surveys also show that government mistrust is high in Native populations and is associated with indicating less interest in receiving COVID-19 vaccination. Finally, many respondents indicated that they were concerned about the new technology used to create COVID-19 vaccines and the speed with which they were produced and recommended. These concerns were also associated with a lower likelihood of wanting to receive a COVID-19 vaccination. And these examples demonstrate the real threat of vaccine hesitancy specific to the disease context, the community we serve, and the specific vaccines that are or soon will be authorized for use to prevent COVID-19. These factors have the potential to drive demand even lower once COVID-19 vaccine supplies become more available. Next slide. So what can we do to address this threat? CDC has already embarked on a campaign to vaccinate with confidence. Our role in this is to build confidence and trust in our ability to vaccinate by ensuring competence through rigorous staff training. Staff involved in vaccination campaigns need to be able to answer patients' questions about the risk and severity of COVID-19 and the effectiveness and safety of the available vaccines. Across Indian country, IHS, tribal, and urban Indian health programs are working diligently to make safe COVID-19 vaccination services available to their communities as much as possible. One communication tip is to avoid trying to debunk myths. If we have learned anything from this past year in the media, the more one tries to dispel myths and falsehoods about anything, including vaccines, the more it actually perpetuates them. So rather than spending too much time on that, simply state that a myth is false, focus on the facts, and use the simplest language possible. Next slide. Another tip is to avoid something called disconfirmation bias. This is when people are told more strongly, this is when people hold more strongly to what they believe, especially when those beliefs are challenged. So instead, provide new information to replace the existing incorrect beliefs, rather than trying to spend time arguing to refute those beliefs. You can also try to pivot the conversation to the disease that we're trying to prevent, but not to the point where you scare them into inaction. Next slide. Do not be afraid to ask patients what questions or concerns they have about vaccination. Use strategies that you may be familiar with from motivational interviewing or expert training to engage with patients by keeping the interaction conversational, asking permission to share more information, express understanding and compassion. If a patient is not ready to receive a vaccination today, help them to develop a plan for when they'll return to either receive a COVID-19 vaccine or to have a follow-up discussion about any remaining concerns. Next slide. So here I've listed a bunch of resources that you can turn to help you in communicating about vaccines with your patients. And I'd really like to stress the top one on this list, which is a new video that was released by the Northwest Native American Center of Excellence last week. I think you'll find it very enjoyable and very helpful in communicating with your coworkers and with patients. Next slide, please. So CDC has a wealth of information as well as links to additional resources on their website, and you can find more information at the URL listed on this slide. Stopping the pandemic is going to take all of our tools, and building vaccine confidence is a critical strategy to increase the uptake and requires a team effort. Thanks for listening and thanks for helping to make this happen. And with that, we'll turn it back to you.
Thank you, Dr. Weiser, for sharing all that information and all of your knowledge with us. It was very helpful. So we have about 15 minutes left. So we'd like to open up this space for any questions or comments from attendees. So as we mentioned at the start of this event, you can do that online, either through the chat or the Q&A box, or if you prefer to share out loud, you can do that by pressing the raise hand button or using *9 if you're on the phone. So we do have a few questions that were submitted by attendees during the registration process. So we're going to start with those. So the first one that I have for you is, does the vaccine prevent you from contracting and spreading COVID-19?
Get unmuted here. So, the vaccine studies didn't collect data on asymptomatic disease or viral shedding. So the evidence-based answer is we still don't know. The J&J vaccine did collect some data on seroconversion, which is antibodies, and that suggests it may help prevent asymptomatic infection because some of the people in that trial had antibody evidence of prior infection. More people had evidence of prior infection in the non-vaccinated group compared to the vaccinated group, even among those who did not have any prior positive tests of symptomatic infection. But we really need more data to substantiate that claim. And that being said, all the vaccines are very effective in reducing symptomatic infection and the severity of infection, such as hospitalization and death. All the vaccines are 85% or better at preventing hospitalization or death.
Great, thank you for that. So the second question that was submitted by an attendee mentions that there are some medical staff who have refused the vaccine. So the question that this person had was, what messaging can we provide to medical staff who have refused the vaccine that they can then provide to patients about the vaccine safety, et cetera?
So this could be a little bit difficult because providers who refuse the vaccine may have made their own personal decision. But these providers would still be expected to provide the same information to patients regarding the vaccine, whether or not the provider themselves have been vaccinated. So the EUA fact sheets that have been released, and these are sort of the equivalent to the vaccine information sheet that we normally give with all approved vaccines. Those EUA vaccine sheets or fact sheets should be provided to all patients. And most of their questions can be answered from information from those sheets. And providers could themselves answer the questions and help walk patients through those sheets if those patients have questions. The other source of information that providers should follow is the CDC clinical considerations. And I can provide the link in the chat maybe. This is this page on the CDC's website lists all of the current precautions and contraindications to the vaccines. It also goes over dosage and administration for the currently authorized vaccines. And so providers are encouraged to be open and honest. However, providers should not inject their own personal opinions into the conversation in an effort to dissuade a patient from receiving the vaccine. If a patient asks you if you were vaccinated, that's your personal choice whether to reveal that information. Certainly, we feel that if you have been vaccinated, that it's perfectly fine and probably helpful to share that information with your patients, as that will actually give them more confidence in receiving the vaccine. Over.
Thank you. And I did drop into the chat one of the resources that you mentioned. So it shows the CDC interim clinical considerations. So you can click on that link for more information.
Great, thanks.
So the next question that we have for you is, somebody wrote in and said, in particular, I would like to know how to respond to why they should get the J&J vaccine.
So there are a number of reasons that someone might want to choose to get the J&J vaccine. We've certainly seen in our area, in many of our clinics, that there are people who didn't get the mRNA vaccines because they had certain concerns and they just weren't sure about those vaccines, but they feel like for whatever reason, the J&J vaccine would be a better choice for them. And so those people are choosing to get that vaccine. Really, all three vaccines are still in limited supply. And to protect yourself and everyone around you, patients are encouraged to get vaccinated with any of these vaccines. And the CDC's recommendation is whichever vaccine is you are offered, that's the one that you should take. The ACIP, the Advisory Committee for Immunization Practices that I mentioned earlier, did not express any preference for one vaccine over any other vaccine for COVID-19. So personal considerations might include one's ability to take time off from work to receive 2 doses of vaccine versus 1 dose. And then also the side effects. If the side effects happen with both doses of a 2-dose vaccine and only 1 dose of a 1-dose vaccine, then people might prefer not to have as many side effects or have that happen again. So that, I think that's one reason that I've heard. The other thing is if you have upcoming travel or are considering a relocation, that might make it difficult for you to get your first dose of a vaccine in one location and then have to scramble to find your second dose in another location or delay it because of some planned travel or something like that. So getting a single dose vaccine might be better in that situation. And finally, the personal consideration and understanding of the vaccine platform, whether it's an mRNA vaccine or the J&J, which is the adenovirus vector vaccine. People will form their own opinions based on what they've read or what they've heard about those 2 different platforms. Hope that answers the question.
Yeah, thank you for that. And I know we spoke a little bit before the event, and you had said that there was a related question that you've started to hear a lot lately, and it kind of stems from people looking at the vaccine trials. And so the question that you said that you've heard is that some people are asking, is the Johnson & Johnson vaccine effective for American Indian Alaskan Natives? So can you give us just a little bit of background on where that question's coming from and your response to it?
Sure. So there is a opinion editorial article that's been published in 2 different places, most recently yesterday on Indian Country Today. And so people might be hearing about that article. So these recent opinions expressed the concern that the J&J vaccine is less effective for American Indian Alaska Native people. But the problem with that, those opinion pieces is that there's really no data to support that conclusion. When a vaccine or a medication trial is planned, enrollment in the trial is based on the number that's needed to prove the pre-planned outcomes or set of outcomes of what we call the primary or secondary outcomes. And this advanced determination of how many people you need to enroll is based on the concept of statistical power. So evaluation of the outcomes in smaller groups within the original enrollment population is called subgroup analysis. And unless there's adequate statistical power, meaning you have enough enrollees or volunteers within those subgroups, then you just don't have enough statistical power to perform subgroup analysis to provide any meaningful conclusions. And just to point out that none of the currently authorized COVID vaccines in the US were statistically powered for subgroup analysis of effectiveness or safety, specifically for American Indians or Alaska Natives. In each case, much less than 1% of the volunteer enrollees were American Indian or Alaska Native in the US arms of the trials. And similarly, all three vaccines are being used in pregnant and breastfeeding women, even though there's not adequate data to determine safety or effectiveness in this subgroup, because this was an exclusion criteria. And the exclusion criteria meant that if you were pregnant, you couldn't even sign up to be in the studies. Even knowing this, the American College of Obstetrics and Gynecology immediately recommended COVID vaccination for this subgroup because they understood the safety and effectiveness of the vaccines in the general study population could be extrapolated to pregnant and breastfeeding women. And the benefit of to these women who are at higher risk of disease complications far outweighs any risks that might be perceived. And we know from the discussion we just had, American Indian and Alaska Native people are clearly at a higher risk for COVID-19 disease and complications. We know that we need to make every reasonable effort to protect them. And we know that there are 3 safe and effective vaccines that have been properly vetted in clinical trials. The bottom line is that all 3 vaccines are safe and effective and should be utilized in the patient population. We cannot afford to wait until and unless there is adequate statistical data to make a determination about specific effectiveness and safety in our patient population. So that would be my response to anyone who's reading that article and having doubts about J&J or any of the other vaccines. Thanks.
Thank you for helping address that. So another one of the questions that we got from the attendees is there any guidance on the duration of antibodies beyond the 90 from being fully vaccinated with each vaccine or booster doses?
Great question. And really, the short answer is no. We don't have any new or updated guidance for this. We've been saying for quite a number of weeks now that if you had previous COVID-19 vaccine, COVID-19 infection, that we think that the antibodies can provide protection for up to about 90 days. And that's based on data looking at the risks of reinfection, and few or no reinfections have been found within that 90-day period. That's where that comes from. We could extrapolate that the vaccines probably provide at least that much protection and probably longer. But remember, we're only about 90 days, just past 90 days, since we've been using these vaccines in the wider population since the FDA authorized the vaccines for release. So once we have more people who've been vaccinated longer than 90 days, we'll have better data to answer that question. And currently, both the vaccine studies, the vaccine trials, and those participants in those trials are still being studied and still participating, and data is being gathered from those individuals. Plus, CDC and the manufacturers are planning and looking at data from people who have received the vaccine in the general population. So we hope to have a better answer to that question soon.
Thank you. So the next question that we have for you is, has CDC found any patterns of adverse effects or safety concerns through systems like vSafe?
Nothing new has emerged since vSafe and since VAERS has been in monitoring for COVID-19 vaccines. They are enrolling a large number of people who are pregnant and who have gotten vaccinated. Like I mentioned, pregnant women were not able to sign up to be part of the trials. A few women did become pregnant while they were in the trial, either between the first and second dose or after receiving the second dose, but not very many. But since the vaccines rolled out, there have been several thousand women who have signed up in vSafe and through VAERS, indicating that they're pregnant. And so far, there's been no safety signals observed for safety in pregnancy that would provide any caution or precaution that should be used. Likewise, we heard a lot about anaphylaxis in the beginning of the rollout of the vaccines. And we've now published, there have been 2 MMWR articles published on safety data from VAERS regarding the mRNA vaccines. And the number per million has dropped significantly, initially from 11 per million incidents of anaphylaxis to now I think it's around 2.5 per million instances of anaphylaxis per million doses of vaccine administered. So the anaphylaxis rate seems to be dropping quite considerably with this new data from VAERS and from vSafe.
Thank you. So I think we have time for probably one more question. So I'd like to ask, what are good ways to explain how mRNA is different from DNA and that the mRNA vaccines are not going to change your genetics? So what's a good way to explain that to patients?
That's a tough one. And I think a diagram is probably really helpful. So in this slide set, most of these slides came straight from CDC, but I specifically added the slides that had the diagrams of how they work, because I find that diagrams really are helpful in visualizing what's happening. But in a nutshell, you have to draw on some knowledge of biology, right? So a cell has a cytoplasm and a nucleus. And mRNA, in our normal cell operations, mRNA is transmitted from the nucleus into the cytoplasm. Once it gets into the cytoplasm, that's when it's read by the ribosome and the protein is produced. And so normally the mRNA does not go into the cell nucleus, which is where the DNA is, but the mRNA comes from the cell nucleus and goes into cytoplasm and makes this simple protein, which is a harmless protein to our bodies. So I would maybe draw a simplified version of a cell, show that the mRNA always stays in that outer part of the cell, never enters into the nucleus, which is where the DNA is. I would probably try to use something like that.
Great, thank you. So with that, we will be closing our Q&A session. So Dr. Weiser, I just wanted to say thank you so much for taking the time to provide this valuable information for us today. Do you have any final thoughts that you'd like to share before we close?
I just want to say that, you know, there's been a lot of articles about vaccination in Indian country and the high uptake of vaccine. We heard that one of the folks who was one of the masterminds in the Operation Warp Speed effort to get vaccines produced recently toured the Oklahoma City area in one of their facilities and was duly impressed with the way that we've been rolling out these vaccines. So I want to just, you know, raise my hands and say thank you to all of you who are doing such great work out there in the field vaccinating, because we are really leading the way. Many of our IHS areas are several percentage points above our surrounding communities in terms of the percent of the population that's been vaccinated, as well as the percent of the vaccines that we've received being administered into the arms of patients. And so every vaccine saves lives. And this goes for not just COVID vaccines, but every vaccine you give. And so I hope that once we get everyone vaccinated against COVID, we can turn our attention to also making sure that our children are fully vaccinated against all the routine childhood diseases that we have well-established approved vaccines for. So keep up the good work. I know people are getting sore hands and sore fingers, but you're doing a great job, and it's greatly appreciated by everyone. Thank you.
Great, and thank you again, Dr. Weiser, for taking the time to present today. And thank you to everyone who attended this event and for the hard work that you do. With permission from Dr. Weiser, we will be sending out a recording of this presentation that you can view or share with others who would benefit from it. In that email, there'll also be a link to a 7-question survey. So please take about 3 minutes to complete that, and we'll be using your feedback to better serve you and your community in the future. Finally, if you have any questions about this presentation, please use the contact information on this slide to contact myself, Julie Nystrom, or one of my coworkers. So with that, thank you again, everyone, and have a great afternoon.
Bye now.